Okay, so it's 3 minutes past. So I think I'll start, if that's okay.
Yep, work away.
So I have to finish on the hour, whichever hour that is, for wherever people are. So the first one is a man who presents with increased immunoglobulins. Was born in 1957, so 60, coming on for 68, 67 at the moment, and this is his marrow. So I think for it's looking at it the whole thing. It's definitely adequate. It's an adequate core. There's a very interesting case actually. There's a little bit of periosteum in the middle, but otherwise plenty of material to go at, and it is hypercellular. And lots of areas of loss of fat spaces with filling in of the marrow. And certainly in this area here, loss of paratrabecular fat spaces. And up here, it's really quite cellular, particularly in this area here. So we have, but the cellularity isn't increased everywhere. There are some areas which are a little more normal. So it's to indicate it's probably infiltrated by some external process rather than an intrinsic bone marrow abnormality like a myelodysplasia or myeloproliferative. So this is more likely either a lymphoid or a myelomatous infiltrate. So looking at it at higher power, we have lots of small dark cells, and at this power, these could either be all these small little cells. At this power, they could be erythroid cells or they could be lymphoid cells. So we really need to look at them at higher power to see what type of cells they are. Already at this power, we can see plenty of plasma cells, like there. There are 2 plasma cells there. There's a whole set of plasma cells through here. And going up to higher power, shows that the infiltrate looks like lots of small lymphoid cells, very dark nuclei, no real small space around. This one here's got a small space, that's probably erythroid. So we've got lots of lymphoid cells, lots of small, slightly irregular lymphoid cells, and also plasma cells there, this area through here, these ones here, some more down here. So it was sent for query workup for myeloma. The aspirate showed 1% plasma cells, but 59% lymphocytes. And flow cytometry was still awaited at the time that I looked at it last week. Let me just see what the flow cytometry shows now, because it must have been reported by now. Let's just open this up. So any suggestions from the audience as to what this might be?
If anyone has any suggestions, just raise your hand and I can unmute you.
Thank you. So the flow cytometry again showed a 58% lymphoid population, but no excessive plasma cells. And there wasn't any clonality demonstrable on the flow cytometry, but that's not uncommon. So there's definitely lots of plasma cells, and the clinical question was query myeloma. So we did plasma cell markers. So this is the MUM1. And you can see there's a very marked expansion of plasma cells. This is nuclear staining for MUM1 in plasma cells. Lots and lots of plasma cells. So definitely an increase in plasma cells. It's thought to be about 25 to 30% of the cells overall, which is sufficient to move it into plasma cell myeloma, but not sufficient for multiple myeloma, where you really need over 60% of the cells present. And this was the CD138. So again, marked increase in plasma cells, and they were clonally restricted, as you would expect. This is the lambda, showing occasional positive cells, and this is the kappa, so definite light chain restriction. So we've got a clonal plasma cell population. So we could have just left it at that and just said, well, this is myeloma, plasma cell myeloma, or plasma cell dyscrasia. But the problem is, what about all these lymphoid cells? So you see in this tower here, we've got lots and lots of slightly irregular lymphoid cells. So we went on to do a lymphoid panel. So this was unexpected, and this is the CD20. You can see a very strong positivity for CD20. I think I estimated about maybe 60% of the cells positive for CD20, certainly in this area here, a very high percentage. And they're also positive for CD79A. I think there's slightly more positivity for 79A because obviously this also includes the plasma cells. But it was negative for CD5 and CD3. This is CD5, for instance. There is a bit of background staining, but it's just this dark staining that we're after here. So this here is positive. This, I think, is all just negative, just like black background blush of staining. So we've got a plasma cell dyscrasia plus a B cell infiltrate. So I think, in fact, this one is lymphoplasmacytic lymphoma, unexpected. So that's what I'm going to sign that out as. Are there any comments or any alternative views for that? Which I'm open to other suggestions if people have got any. And just raise your hand, and we'll, if you want to say anything or put it in the chat. It's difficult for me to see the chat with all the different controls I have to have open, but Lydia will see them. No, I think a clear case, but always good to think. It just illustrates that it's always good to think about a lymphoproliferative disorder when you've got clonal plasma cells, because there might not just be pure myeloma. It may be part of a lymphoproliferative disorder, as it was in that case. I think if the lymphoid components had not been as high in that case, we might not have thought to stain for it. But obviously there's an overwhelming infiltrate of lymphoid cells, which were not accounted for by all the plasma cell markers. So that made us go hunting for what the lineage of those lymphoid cells was. Okay. The next case from my colleague. I think I'll alternate between my colleague's cases and my cases. A bit more interest. So let's bring up the clinical record for this case. Okay. So this is actually 16-year-old. 16-year-old male. Unusual for it to come through the adult service, actually. And presents with a high white cell count. So we have a separate pediatric service. I'm surprised this didn't go to the pediatric service. But then we also have a teenage and young adult a specialist teenage and young adult oncology service. So that will deal with, older teenagers, probably from 14 upwards, up into people's mid-20s or maybe even late 20s. And so this has probably come to, and it's the adult service that deals with those, the adult clinicians. So that's probably why it's come to our service rather than the pediatric service. Okay, so it's definitely an adequate biopsy, very adequate core. It's maximally hypercellular. And I think even at this power, you can see there's not much variation in the cell size and shape. So all the cells look similar, kind of small to medium, round, blast-like cells. Some of them have got slightly grooved nuclei. They've got relatively distinct, though not prominent, nucleoli, and a small amount of eosinophilic cytoplasm. And it's the same all the way through. There is also some eosinophilia here, eosinophilia here and here and here. You can show that on the Giemsa quite nicely as well. This is the, yeah. So here's the Giemsa. So we've got lots of mast cells and eosinophils, lots of granulated precursors in this marrow as well. And that might be a feature of this particular type of AML. I'm not quite sure. Let's just see. Okay, yeah. So this, going back to the H&E, so large amount of eosinophilia. I think a very high percentage of blasts, pretty much all the cells are blasts. My colleague reported it as being, I thought about 30% blasts actually. So got all these blasts. No real myeloid differentiation. That's probably the most mature cell there, a band form, nothing else. The immunos for that. So positive for myeloperoxidase. Strongly positive for CD33. It was negative. Sorry, it was also positive for CD34. So there's the 34. So it's thought about 20% positivity for CD34. And was also positive for CD117. Now, CD117, you have to be a bit careful in interpreting because erythroid cells can also be positive, but this is a similar proportion to that we had with 34. So it's 34 and 117 positive. And this is a case of AML. And the interesting thing about this AML is that it had a mutation in it. So it had let's just bring up the clinical history. This had a CBF MHY1 mutation. So it's a genetically characterized AML with CBF MHY11 fusion, and that type of AML is specifically associated with eosinophilia. So it fits together the high eosinophils. I don't think you could suggest that otherwise without knowing the genetics, but I think you could say there's something slightly unusual about it because of the eosinophilia in this case. Otherwise, a relatively straightforward case of AML. So this results from a translocation or inversion in chromosome 16. And it's a favorable risk, one of the favorable risk AMLs. So it's important for that purpose. Yeah. So if I just bring up, I just put the AI summary in the chat. I can get to the chat. Where's the chat gone? So chat. Won't let me put anything in the chat.
Not allowing you to put anything in the chat.
Oh, not allowed me to paste it in. Oh, it allowed me to type it in, but nothing else. Okay. Let's just take this then. Okay, that's worked. Okay, so that's the subtype of AML that this is, and it's characterized by eosinophilia and myelomonocytic differentiation. That's why it was CD33 positive, as well as myeloperoxidase positive. So I'll take another case from one of my biopsies that I did. So this one is a woman born in 1981. So she's 43 at the moment. And she's got a history of cutaneous mastocytosis. So this is a very interesting biopsy. And it forced us to look into the criteria for systemic mastocytosis, which I'll just bring up and we can discuss those. It's a good learning point. So okay. So this was an interesting case. Patient, so they've got cutaneous mastocytosis, dermatologically proven, and a bit of a scrappy biopsy. Normocellular. All three lineages are well represented. Can't see any obvious, so here we're looking for mast cells. Can't see any obvious kind of aggregates of mast cells through the biopsy. Got a lymphoid aggregate there. Again, looking to see if there are any mast cells. All three lineages well represented. Another lymphoid aggregate there, which could be reactive. No obvious mast cell infiltrates. So we did some immunohistochemistry. on this, and what we did CD117, which is a good marker of mast cells. So just look across it. We have got, I think, an increased number of mast cells. And I think a high proportion of them are spindle shaped. So this one here, this one here, this one here, this one here. So you've got a high proportion of spindle-shaped mast cells through the biopsy. Probably, I'd say at least 25% of the mast cells are spindle-shaped. These aggregates are not aggregates of mast cells, so they're negative for mast cells. These are lymphoid, and they're a mixture of B and T cells on immuno. But all the mast cells are lying singly, and we haven't really got any aggregates of mast cells. So an increased number, and also looked for CD2, which is aberrant staining. So we've got CD2 positivity in these aggregates because there are T cells in these aggregates. And also some of the spindle-shaped mast cells are CD2 positive as well. So for instance, we've got this cell here, CD2 positive mast cell. We've also got a mast cell tryptase, and you can also pick up these mast cells on the Diagnexia. And this is it on the Diagnexia. So there's a lot of eosinophilia, but there's also an increased number of mast cells. A bit harder to see on the Diagnexia than on the immuno, actually. So the question was whether this represented systemic mastocytosis or not. So what we did is reminded ourselves of the criteria. I'll just bring up those criteria to share a new screen. This is it. Yeah. So here's the criteria. So systemic mastocytosis, there has to be either a major criteria. So with the major criteria is infiltrates of mast cells with 15 cells in aggregate. So there are no aggregates of that. So the major criteria is not present. Or you can have 3 of the minor criteria. So I think we've got more than 25% are atypical spindle cells. But otherwise, none of these other, and also they did exhibit CD2 positivity. So we've got 2 of the minor criteria are fulfilled, A and C. But we looked at the genetics, there was no KIT point mutation, and the serum tryptase was less than 20 nanograms per milliliter. So this case, even though the patient has cutaneous mastocytosis and an increased number of abnormal atypical cells, mast cells in the bone marrow, still didn't fulfill the criteria for systemic mastocytosis. So we reported it as showing an increased number of mast cells, but insufficient for a diagnosis of systemic mastocytosis. In this instance, if there'd been a single aggregate of more than 15 mast cells in the marrow, or there had been a KIT point mutation, or serum tryptase level was slightly higher. If any of those had been the case, then it would have been systemic mastocytosis, but it didn't make it on this occasion. And I think it's a reasonable core. So you could argue that, well, you didn't see one of these infiltrates because the marrow was small, so you didn't sample it. But I think it was a decent core, an adequate core. So I think this patient has got away with without a diagnosis of systemic mastocytosis. And it could well be that they're increased in the marrow just as part of the kind of response to a cutaneous mastocytosis. Okay, what have we got else? So systemic mastocytosis is, of course, a myeloproliferative neoplasm. So we've got a couple of those to show as well. So I'll go on to the first one. This is a man born in 1962, so it's coming up for 63, 64 at the moment. Sorry, 62 at the moment. And it's query myelofibrosis. So let's just see what we've got. I'll stop that share and go back to sharing. So I think that our workload is not only going up, but it's also becoming more complex. We're seeing a lot more subtle things than we used to in the old days. Maybe we're just looking a bit more carefully. I don't know. But those were both, the first one I showed could have been really straightforward, just myeloma, but it turned out to be something different. And then that one that I've just shown would usually just turn out to be systemic mastocytosis, but again, wasn't quite as straightforward as that. And then the AML with the eosinophilia and the mutation wasn't as straightforward as just acute myeloid leukemia, NOS. So there's a patient born in, so they're 62. And it's quite a cellular marrow, this, actually. Let's bring up the report. So it's a male born in 62. And it's post-chemotherapy. The patient has been treated. So this patient had polycythemia vera, which then transformed to secondary myelofibrosis in 2004. There was a JAK2 mutation, and they went on a trial. And this is post-treatment. So this can be a little difficult to interpret, myelofibrosis post-trial. If you just rely on looking at fibrosis or the bones, you'll be disappointed because they take a bit of time to remodel out. So you can see a very thickened sclerotic piece of bone here. These do take a long time to resolve after chemotherapy, maybe a year or so. And the fibrosis can also persist, but what you're really looking for is, are there any atypical megakaryocytes left? In terms of the bone, one thing to mention about the bone is that we've got a small area of woven bone here. And also what we've got is, people don't often talk about them, but these lines, see these purple lines in the bone? So these lines can be quite instructive. This line here and this one here. These are cement reversal lines. And cement reversal lines are where the bone has stopped growing and then starts growing again. And you get this slightly denser area of kind of calcification just at that junction point. So we've got evidence of very focal woven bone in this area, evidence of new bone formation and successive waves of new bone formation with the bone stopping and then regrowing with these subsequent cement reversal lines. Also looking at the Haversian canals, you can see there are nuclei within most of the canals, which is good. It shows the bone is viable. When you get necrotic bone, you will lose those nuclei out of these little holes. You can accept that some will be empty due to cross-cutting artifact. So the fact that these ones here haven't got nuclei in, I wouldn't necessarily say that that was a necrotic piece of bone. I think that's just due to cross-cutting. Anyway, this is an interesting biopsy. So we've got some post-chemotherapy effect. We've got some hemosiderin here, got some myxoid change here. And it's not particularly cellular. and the fibrosis is not particularly high either. No streaming effect. But what we have got is lots of groups of atypical megakaryocytes. So where you see, it can be difficult assessing these because after treatment, you can quite often get atypia in the megakaryocytic lineage, either architectural or cytological or both, due to response to rapid regrowth. But even so, you shouldn't get large clusters like this. You might get 1 or 2 clustering together, but here you've got at least 3 and maybe 4 clustering together. That's a very atypical megakaryocyte there as well. So when you're assessing whether myelofibrosis is persistent, then really you're looking at the megakaryocytic abnormalities. And everywhere we look, we're retaining these clusters of megakaryocytes there, there, there. There's quite a lot up in this area as well. There's another one there, and so on. So on the basis of these atypical megakaryocytes, this patient was considered to have ongoing myelofibrosis. There is no excess of blasts. So if I show the fibrosis, so we use a reticulin and then a trichrome stain. So there is still, even though there wasn't much streaming artifact, we still have grade 3 reticulin. So we have thickened bone, which is part of the osteosclerosis, is part of the WHO classification for criteria for myelofibrosis. And then obviously the collagen here is stained kind of magenta pink color. And you can see there's a slight magenta tinge in these cells here. They're not just quite jet black. They've got a slight purple haze to them, particularly there around a blood vessel. But in this area here, again, a purple haze. In these, they're not just jet black. And that's because there's collagen here as well. Some people say you can see that there's collagen fibrosis because the fibers, the reticulin fibers become wavy. So you don't need to do a trichrome. I think that's wrong. Here you can see that they're definitely not wavy. They're nice straight lines, and yet we definitely have collagen purple staining in this area. I think the simplest thing is not to try to be too clever, and just do a trichrome crown stain, and then you don't have to be clever about it, and you've got the answer straight in front of you. So there is still fibrosis, grade 3 fibrosis, and there's still megakaryocytes. So this is persistent myelofibrosis. Yeah, persistent myelofibrosis. Okay, I can show you the megakaryocytes. The CD61 stain, usually you can see them quite well in myelofibrosis. And here they are. So we've got large numbers of atypical clusters. Now, as I said, you could say, yeah, but, patient's been treated, it's post-chemotherapy, it's regenerative marrow, you're going to get abnormal, we know that you can get all kinds of slightly dysplastic looking features in a regenerating marrow. But I don't think that's the case here because these clusters are just too big and there are just too many of them. So I think this is residual myelofibrosis in this patient. Right, I'll go on to another case of myelofibrosis actually. And then I'll see what else I've got in my collection. So that was another case of AML. We've already seen some AML, so we don't need to see more AML particularly. So this one here, let me find that. Okay, yeah. So this patient presented as a 86-year-old man. Gosh, you think, gosh, you know, you get to 86 and you have to have a bone marrow. You're doing well. It's got a hemoglobin of 108, white cell 20.8, platelets 483. So they say he's got a thrombocytosis. It's only mild, actually. Upper limit of platelets like 450, and it's only 483. It's got leukocytosis. Yep, it's definitely got high white cells at 20.8. He's got mild anemia, 108. Normal hemoglobin for a man's probably 13.5 or thereabouts. For an 86-year-old, it might come to about 12.5 for a man. So let's look at his marrow. So certainly a very good core. Bony trabeculae, they're a little bit thickened in places, I think. Maybe here. It's a bit dirty, that, isn't it? Let me just clean it a little bit, see if that makes a difference. No, it doesn't. Okay. A bit thickened, the trabeculae. And the cellularity of the marrow, it's definitely increased. It's variable, like we saw in that first one. But there are definitely increased areas. And then at this power even, we can see lots of megas there, there, and this group spilling through there. There's also a minor degree of streaming artifacts due to increased fibrosis, the cells lying along lines. So you've got an area of megakaryocytes there, and some here. Also got little clusters of megakaryocytes here. They've got very abnormal nuclei, another cluster there. And it's associated with increased myelopoiesis and well represented but slightly disrupted erythropoiesis. So looking at the retic for this one, the retic isn't increased as much as the other one. So the other one was up to grade 3. This one, we have got coarse fibers, but I don't think we've got the same degree of collagen fibrosis here. I think this is just grade 2, and we haven't got such strong osteosclerosis. So I think we've got focal grade 2. There are coarse fibers here, and coarse fibers equals grade 2. The megakaryocytes are increased. Extremely hot in this room, but really not as hot as anywhere where all of you are. So you can see this really highlights how much megakaryopoiesis there is. Absolutely tons and large atypical clusters. So the preferred diagnosis for this one was cellular phase myelofibrosis, because it hasn't really established that full-blown grade 3 reticular fibrosis, but it's being driven by still the increased megakaryocytes. It begins to flag in this heat, actually. So we'll go to one of mine now. Oh, it's very, very hot in this room. I'll put that one with today's work. So I'm just going to look up the integrated report for this one. This is a bit of a tricky case. Patient born in 1951. So that makes them 70, 70, actually 74 now. Then a hemoglobin of 111, white cells 7.3, platelets 322, which is normal. Neutrophils 5.0, which is a bit high. And it was query chronic myeloid leukemia. So I just want to have a look at this one carefully. Yeah. It came from another hospital. Sometimes the history we get when they come from another hospital is a bit variable. So this is it. So it was a good quality trephine. I think for the age, 80, 84, excuse me, almost maximally hypercellular. You can see even at this power, I got some atypical megakaryocytes like here and here. And there's an awful lot of increased myelopoiesis in the background. There's also a lot of eosinophilia. This was also one with lots of eosinophils. I'll just show you the Diagnexia for that. So this is the Diagnexia. Yeah. So in this field here, a lot of eosinophilia. So you often get eosinophilia in myeloproliferative neoplasms, so that's not surprising. Looking at the H&E. Yes. A nice part of the section. Okay, this is quite representative. So, oh, a little bit of a breeze coming in. Thank God for that. So atypical megakaryocytes, some erythropoiesis here, and the rest of it very left shifted, but maturing. There's some neutrophils here. I'm not sure if these are neutrophils or apoptotic cells, actually, but that certainly is a neutrophil there. These might actually be small apoptotic cells, to be honest. But there is some neutrophilic differentiation again here and up here, here, and so on. So, the question was whether this amounts to chronic myeloid leukemia. It's interesting because the white cell count isn't particularly high. It's only 7.3. Otherwise, I think this does fulfill the criteria for chronic myeloid leukemia. We've got increased megas, massively increased myelopoiesis with maturation, but also left shift. Some preserved erythropoiesis, usually a bit lower than in this case, but they've often got marked megakaryocytic expansion and hyperplasia and dysplasia, and also increased eosinophilia. So morphologically, this is consistent with a chronic myeloid leukemia. What's interesting about it is that the white cell count isn't particularly high. So you kind of think, So this is characteristic of chronic myeloid leukemia, these kind of like seams of very immature myeloid cells, like here, which then go on to mature into neutrophils. So you've got all stages of myelopoiesis well represented. But the question was, why is the white cell count low? Not that high. It's only 7.3. So that was the one thing that we wondered went against it being chronic myeloid leukemia. So I'll just bring up the integrated report for this case. So it had a demonstrable, so the BCR-ABL transcript was detected by molecular genetics, and it was thought to be chronic phase chronic myeloid leukemia. And the reason why there wasn't such a high white cell count is that the patient had in fact received some initial treatment before they came in, which probably increased the amount of eosinophilia and increased the amount of erythroid differentiation and decreased the white cell count. So I have to take that into consideration, that sometimes if a case has come to you, it's already been pre-treated, it might not show all the typical features that you might expect in that condition. So in this condition, the white cell count was quite a bit lower than we would expect for chronic myeloid leukemia. So that's the thing about heme path, is often a very wide story to be taken into consideration. Well, I've got another one which should be quite straightforward actually. But again, it was a clinical conundrum, this one. So this patient, born in 1954, so they're 70, 71 now. They've got a peripheral blood lymphocytosis, and the cell markers are consistent with CLL. But recently they've had a dropping full blood count and platelets. So neutrophils 1.2, so that's a bit low. Platelets 93, that's really quite low. And hemoglobin of 112, so 112. So that's a bit low for their age, not too low. So why have they got cytopenias? I think the reason is quite clear. If you look at the biopsy, it's a good, adequate core, and it's completely full of atypical lymphoid cells. There's no evidence of transformation. There are no blasts. The reason why the cytopenias is there's virtually no normal hematopoiesis left in this marrow. So, in fact, given the density of the infiltrate, I think it's surprising they've got any. Their cytopenias aren't more severe than they are. The hemoglobin's 112. It's not too bad. Platelets 93. Well, we see lots of people with platelets under 50 or even under 20. So I think they're doing quite well to maintain some kind of peripheral blood output, despite this very dense and very extensive infiltrate of chronic lymphocytic leukemia, which is demonstrated on the immunos. So there's CD20, which is pretty much 100% of the marrow is occupied. Okay, I'm probably going to have to stop there because I'm really running out of steam.